Thank you for the invitation. I'm honored to be here again. I'm Christine Parseghian, professor at GI Medical Oncology at MD Anderson Cancer Center with a focus on colorectal cancer, specifically kind of overcoming resistance. So this talk is going to be about mechanisms of resistance to EGFR-targeted therapies, particularly beyond what we know now, which is kind of acquired genetic mutations. These are my disclosures. So a little bit of background about anti-EGFR and acquired resistance. So as we know, anti-EGFR therapies such as cetuximab and panitumumab are combined with chemotherapy and have resulted in improved outcomes in wild-type tumors. However, almost all of these patients will develop, obviously, resistance within at least 8 months of therapy initiation. We have known so far that the development of acquired resistance to anti-EGFR kind of has to do with some genomic mechanisms of resistance. However, we also know that there are potentially some non-genomic mechanisms that have been proposed. We know that KRAS, NRAS, BRAF, MAP2 kinase 1, and EGFR ectodomain mutations have been shown to be kind of sources of acquired genomic resistance. But we know that they are really only seen in about 40 to 50% of patients. So really this leads to the question of what additional mechanisms of resistance are there in this patient population. We know that studies, thankfully utilizing those resources of, the great resources of ctDNA have demonstrated that acquired RAS and EGFR ectodomain mutations, for example, can decay over time exponentially, and we've shown this here at MD Anderson with a half-life of essentially 4.4 months, such that we know that over time these mutations, again, decay are lost, perhaps allowing us to re-challenge after that point in time. And of course, this has kind of been a little bit of the backbone to kind of the hypothesis behind anti-EGFR re-challenge. There have been several studies to date that have been published. The CRIC-IT trial was one of the first. It showed kind of early efficacy for cetuximab re-challenge, particularly in patients with RAS wild-type ctDNA. So this was a phase 2 trial. It looked at patients with RAS wild-type, BRAF wild-type CRC in the tissue. These patients were treated with cetuximab and either FOLFIRI or FOLFOX in the first-line setting, and then had an intervening non-cetuximab-based regimen, which was then followed up with cetuximab re-challenge plus irinotecan. They did do a liquid biopsy prior to re-challenge and analyzed it retrospectively. Primary endpoint here was overall response rate. So they did find when they looked at the RAS wild-type patient population, so again, they looked at the liquid biopsy and then analyzed retrospectively, and they looked and patients who had not acquired any RAS mutations in the ctDNA at the time of re-challenge had a very superior response. The progression-free survival was 4 months compared to 1.9 months if this patient population had acquired a resistance mutation. Similarly, the overall survival was quite. So again, this trial looked, this is the KRONOS trial. This trial looked this time prospectively using ctDNA analysis to guide selection. So these patients had received anti-EGFR prior and had responded with either a CR or a PR, and then had any kind of anti-EGFR-free regimen after progression. Finally, when they progressed on the anti-EGFR agent-free regimen, they did get a liquid biopsy, and patients who had acquired a RAS mutation were disqualified. Patients who had no RAS mutations at the time of proposed re-challenge were re-challenged with panitumumab single agent. Here, the primary endpoint was overall response rate of greater than 30%. They did meet their primary endpoint. The overall response rate was indeed 30%. The disease control rate at 4 months or greater was 63%. And the progression-free survival was essentially the same as the CRIC-IT trial of 4 months. So clearly this is good in relation to what we have in the third line setting, which of course we know is either fruquintinib or long-term Avastin, with an overall response rate of about 5 to 6%. So of course, an overall response rate anywhere between 20 to 30% is great, but the question is, how can we do better, and why a majority of these patients are actually not responding to rechallenge. So there are ongoing kind of randomized control trials, which will hopefully help us kind of understand further in a large proportion of patients if this rechallenge protocol works. We know about the FIRE4 trial, which is a phase 3 trial, looking at patients who were previously untreated with RAS, were randomized to either cetuximab and FOLFIRI versus cetuximab and FOLFIRI induction and Bev-5FU maintenance, again, versus cetux FOLFIRI the entire time through induction and maintenance. This was then followed in second line with an anti-EGFR free therapy. And I think the question we're all waiting for is, upon that second randomization, these patients will be given cetuximab plus Areno or FOLFIRI versus physician choice with no anti-EGFR. And this, just because of the sheer number of patients, will really try to help us understand what that ORR really is and the PFS with this study. But again, I think the limited efficacy that we've seen so far in the two studies that have been published really raises the question about possible non-genomic mechanisms of resistance. So the differential really of acquired mutations in the frontline versus second line setting has been a question of interest. Again, we know that the conventional understanding was really acquired resistance to anti-EGFR as a result of acquired alterations in the MAP kinase pathway. We discussed those are KRAS, NRAS, etc. However, those are only happening in 40 to 50% of patients that are exposed. Further, we haven't had a lot of information to date because most of these studies actually use anti-EGFR in later line settings. So thankfully, especially internationally, we've seen kind of more of a trend in using anti-EGFR in the frontline setting. So further data is really kind of emerging from resistance in the first line setting in combination with cytotoxic chemo, and trying to understand kind of how these mechanisms of resistance are different in patients that receive frontline versus second or greater line treatment with anti-EGFR. So we did a study here at MD Anderson looking at plasma samples at baseline of 3 large clinical trials. So there was a first-line trial which looked at FOLFOX and panitumumab versus FOLFOX alone. We looked at plasma samples at progression in these patients, and again, this was a first-line study. We then had 2 third-line studies which we evaluated the ctDNA for. The first one was the 007 study. It looked at best supportive care plus PANI versus best supportive care in the third-line setting. And then finally, the second third-line study that we evaluated was a PANI versus cetuximab trial. We found pretty stark responses in regards to the first-line versus third-line setting. Here, the resistance mutations are in green and are defined as any mutations in KRAS, NRAS, BRAF, MAP2 kinase 1, or EGFR ectrodynamine mutations. All the other mutations are in purple. And you see that the rate of acquired mutations of patients receiving FOLFOX plus panitumumab in the first-line setting is very low, 9%, with majority of patients not have acquired any of these known resistance mutations. However, if you look in the third-line setting, and again, we're looking at those same resistance mutations, you can see very different situations. So you can see that the rate of acquired mutations in patients receiving anti-EGFR as a single agent in rechallenge, near majority of these patients, at least half of these patients, 47%, had a acquired resistance mutation. So very different than the first line. We saw a similar situation in the second, third line study that we evaluated. Again, patients receiving only single agent, the anti-EGFR, in the third line setting had only acquired mutations in 39% of cases. So again, I think in the first line study, you can kind of see here the rate of anti-EGFR resistance mutation and acquisition in the anti-EGFR arm was 9%. This was really no different than in the non-anti-EGFR containing arms. So if we look in the first line setting, really there was no difference in acquired mutations if you looked at patients who received anti-EGFR versus not received. However, if you looked at the randomized third line study, acquired anti-EGFR resistance mutations were seen here in 39% and 0% of patients in the panitumumab and best supportive care treated arms, respectively. So very stark difference. Now, I think, conventionally, we know that kind of like a Darwinian selection has really been the predominant hypothesis here to rationalize kind of the development of acquired resistance to these targeted therapies. By this theory, us and many colleagues internationally have kind of hypothesized really that resistance is generated by the progressive domination of kind of these pre-existing therapy-resistant subclones that outgrow and as anti-EGFR kind of pressure is applied. But more recently, we've kind of had an alternative hypothesis that is known as kind of adaptive mutability, which the Italians had published a few years ago in Science. And they kind of showed a mechanism which is implicated in progression, which is kind of a model suggesting a temporary switch from kind of a high fidelity to an error-prone mutagenic state under therapeutic stress. So not a Darwinian outgrowth of subclones, but rather a temporary switch into kind of an error-prone mutagenic state. So more of a transcriptional change. So we wanted to test this hypothesis. So we looked at passenger mutation burden, which is defined as essentially alterations other than KRAS and NRAS EGFR mutations that may emerge with first line versus third line setting with anti-EGFR. We actually found a big difference here as well. We found that passenger mutations were threefold greater in the third line setting, 1.4 versus 0.4 mutations respectively here. And patients who had ctDNA evidence for acquired RAS and EGFR alterations were more likely to develop additional passenger mutations than those who did not. And that was a 2.3 or 2.1 rather versus 0.9 respectively. So really taken together, you can see in these two graphs, these results really suggest that there may be this heterogeneous pattern of acquired resistance related to chemotherapy combinations and sequencing, and have really important implications for appropriate patient selection for anti-EGFR retherapy and other targeted therapies, in fact. So we looked again, at baseline in these patients, and we found that at baseline, 27% of patients that were treated with anti-EGFR had a baseline subclonal resistance alteration. So if this was kind of a Darwinian selection, we would expect that these subclones would outgrow over time. But there were a total of 171 subclonal resistance mutations among these patients. 8% only became clonal, 47% stayed subclonal, and 44% were absent at the time of progression. So really, this argues against the Darwinian selection hypothesis that we had discussed, and really opens the possibility of chemotherapy driving resistance in the first line setting, even when combined with targeted therapies. Then we looked kind of to further explore this. We looked at kind of translational studies to evaluate cell lines with and without acquired cetuximab resistance, and showed that both phenotypic and gene expression profiles were consistent with EMT signature, so epithelial to mesenchymal transitions. We saw that TGF-beta, which is kind of a defining characteristic of the CMS4 subtype, was notably upregulated in the cetuximab-resistant cell line compared to the parental cell line. We also found additional confirmatory testing, which showed concomitant increase in E-cadherin, snail, slug, and vimentin, which are basically all proteins that have been shown to have a critical role in kind of epithelial to mesenchymal transition. So also to kind of further on this, we then look to evaluate anti-EGFR efficacy after chemotherapy. We looked at several 5FU, oxali, and SM38 resistant cell lines that were treated with cetuximab, and they showed that they were less sensitive with prolonged anti-EGFR exposure. And, obviously this is limited in vitro data, but really along with the genomic data that we talked about, it really suggests that these CRC cells may develop resistance to chemotherapy and anti-EGFR through these non-genomic mechanisms compared to kind of later lines when anti-EGFR is given as a single agent and is driving more of a genomic response or resistance. So in summary, I think evidence is certainly emerging in regards to what is driving resistance against anti-EGFR. Anti-EGFR rechallenge with ctDNA monitoring has really been clinically adopted in CRC. However, kind of a third of these selected patients with RAS wild-type tumors who have had prior benefit from and then subsequently progressed and were rechallenged, even if they had, no acquired MAP kinase mutations, responded. But again, what is happening to the other 70%? Why are the other 70% non-responding? So our studies kind of suggest here that these non-genomic mechanisms of resistance may predominate here when anti-EGFR therapy is combined with chemo, as seen in the first-line studies compared to third-line, which really argues against the Darwinian kind of selection hypothesis, which is basically chemo driving resistance even when combined with anti-EGFR. So we do think that single resistant kind of profiles, including transcriptomic, epigenetic, and tumor microenvironment changes, rather than resistance to single components of the regimen, is kind of what is happening here. And really, this is very important because really understanding how these mechanisms of resistance differ between kind of multi-drug regimens, how it differs between, double agent versus single agent, really have implications in our ability to generate kind of future successful combination therapies, particularly in the third or greater line setting, in the rechallenge setting in particular. Again, I would like to thank the organizers for the kind invitation, as well as my team here at MD Anderson, the patients who've been kind enough to give us this data and support our studies, and of course the funding support from my institution and through the NIH. Thank you so much. I'm happy to take any questions.
Perfect. Thank you, Professor, for a great lecture. I believe this is a hot topic in the whole world of GI malignancies. Let's see, do we have any questions in the chat and from the audience? I don't see any. So I will ask you about your everyday clinical practice. How do you implement this? I mean, we know that in patients with right-sided colorectal cancer, maybe there is no such, I would say, dilemma how to proceed in first line and everything. But you are aware of ESMO guidelines regarding the left-sided colorectal cancer and EGFR wild type and patients who are not, I would say, suitable for local treatments. How to proceed? What is the duration of first-line chemotherapy with EGFR? How do you do that? Thank you.
Yeah, so I actually support the ESMO guidelines. I wish the ASCO kind of also and NCCN kind of also acquired this. I do support anti-EGFR in the frontline setting in all of my patients with RAS wild-type left-sided tumors. This is truly because now there is this evidence for third-line, availability of rechallenge, and you really do need this intervening regimen to allow those kind of acquired resistance mutations or that resistance to kind of decay over time. And I do think that third-line therapy with anti-EGFR is clearly more effective than the Lonsurf that we have, or fruquintinib, of course, at least in 30% of patients, right? If not more. But clearly there's still a lot to learn, but I absolutely am a proponent of first-line anti-EGFR. Ideally, if you are able to check ctDNA and get that information quickly in the first-line setting before kind of complete NGS molecular profile is resulted, that would be great. I do think it would be more beneficial than giving me Avastin in frontline setting.
Perfect. In your patients, what is the duration of first-line chemotherapy in EGFR? You stopped after 8 cycles, for example, and stabilization of disease and go to the drug holiday, or do you do maintenance?
I do kind of a tribe approach, even if I'm not using Bev. I would do 8 cycles followed by a maintenance regimen in this situation. I know there's a lot of data for switch maintenance as well. You could do 5-FU. Occasionally, I'll do 5-FU Bev in the maintenance setting. Or alternatively, I would do kind of a 5-FU cetuximab. But usually it's 8 cycles of frontline cytotoxic with anti-EGFR, followed by a maintenance after 8 cycles for as long as I can get them.
Perfect. Thank you. This is, very hot topic and maybe still not resolved in the whole oncology world, but we are waiting for all this data.
There's still a lot very much.
Of course. Thank you so much for the invitation.
Thank you. Do we not hear anything from the chat? So thank you, Professor. Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.